Um, so my name is Joyce. I'm one of the consultants in clinical genetics. So I'm going to be talking about genetics of breast cancer today. I would like to start my talk with some numbers, just to give us an idea of the extent of this problem in UK. Most of you might be familiar with these numbers. These are the latest numbers published by ONS in November last year. So over 49,000 women and nearly 400 men were newly diagnosed with breast cancer in the year 2010. So if you look at the age distribution, majority of the women, over 80% of women were diagnosed with breast cancer after the age of 50 years, with more than 45% of them being diagnosed after the age of 65 years. So most of the sporadic breast cancer in the general population seems to occur after the menopausal age, after the age of 50 years. And this is the difference between sporadic, this is one of the differences between sporadic breast cancers and breast cancers due to inherited cancer syndromes, where they tend to occur more early on in life. Looking at the bigger picture, if you look at the worldwide data, the incidence of breast cancer is highest in Western Europe and Northern America, and UK stands 6th amongst the European countries. So if we look at all breast cancers, we now know that all breast cancers have a genetic component to them. And about 20% of women with breast cancers have a family history of breast cancers. And it's a small percentage, the red block at the end, about 5% of these breast cancers are due to an autosomally dominant inherited gene mutation like the BRCA or the TP53 gene mutation. But these breast cancers that occur because of an inherited cancer predisposition syndrome tend to have an incidence of increased second breast cancers associated with other cancers such as ovarian cancers, and these women have a significantly increased risk of breast cancer during their lifetime. We are talking about over 80% risk during their lifetime. Now, this is a graph I've taken from a meta-analysis that was published in Lancet in 2001. So this meta-analysis took into consideration 52 epidemiological studies from around the world. And what they were looking at was how is the family history of having a breast cancer related to the risk of a woman developing breast cancer during her lifetime. So if you consider a woman in her 20s with no family history of breast cancer, then her risk of developing breast cancer during her lifetime, that is by the age of 80 years, is 7.8%. But if the same woman has one family member with breast cancer, her risk would be 13.3%. And if the same woman in her 20s has two family members with breast cancer, then her risk of developing breast cancer during her lifetime is tripled to 21%. So, what are the features that we as geneticists take into consideration while deciding whether a specific breast cancer is because it's a sporadic breast cancer or if it is because of an inherited gene mutation? Are these different factors? So we take into consideration how many relatives within the family, first degree or second degree relatives, have been diagnosed with breast cancer. If any of these relatives have been diagnosed with other related cancers, such as ovarian cancers or prostate cancers in men. If these breast cancers have been diagnosed early on in life rather than after 50 years, that's what happens in sporadic cancers. But with inherited cancer predisposition syndromes, breast cancers tend to be diagnosed early on in life. If there is any family history of bilateral breast cancers, or say, for example, a family member had a breast cancer, then goes on to develop a second primary breast cancer during their lifetime, or goes on to develop another related cancer, such as ovarian cancer during their lifetime. These are all the features that make us think that this might be due to an inherited cancer predisposition syndrome rather than sporadic breast cancers. One of the important things that we take into consideration is the histopathology of some of these cancers. Say, for example, ovarian cancers. we now know that serous and epithelial type of ovarian cancers are more linked to BRCA mutations than some other type of ovarian cancers, say for example borderline or mucinous ovarian cancers. And also the receptor status of breast cancers. So if a woman is diagnosed with breast cancer before the age of 40 years, and if the breast cancer is triple negative, what I mean by triple negative is they are estrogen receptor, progesterone receptor, and HER2 receptor negative breast cancer, then there's 10% risk of them having a BRCA1 mutation. So these are the kind of information that would be useful for us as geneticists to decide if these breast cancers could be because of an inherited syndrome. Now, what is the difference between sporadic breast cancer and breast cancers due to inherited cancer predisposing syndrome is, as I said, breast cancers tend to occur at a younger age. There would be implications for other unaffected family members because they might be at risk of having inherited this particular gene mutation. There would also be an increased risk of developing a second primary breast cancers in these women who have already been diagnosed with breast cancers. And they will also have an increased risk of developing other related cancers, such as ovarian cancers, or maybe prostate cancer in men in the family. Now, we know that cancers are caused due to unregulated, increased cell division and because of prolonged cell lifespan of cells. Now, while understanding the biology of cancer, it's a simplistic way of understanding it is to compare the cell cycle regulation with a bike ride along the slope. So you could regulate the speed of your bike either by controlling the speed at which you pedal or perhaps by applying brakes. So in the same way, the cell cycle is regulated by a set of genes which promote cell growth called the proto-oncogenes. And there are another set of genes called the tumor suppressor genes and the gatekeeper genes which actually apply brakes to the cell cycle growth. So it's a fine balance between these sets of genes that maintains the cell cycle regulation. And if there are mutations in say for example the proto-oncogenes, there are activating mutations in proto-oncogenes, or for example mutations that decrease the activity of tumor suppressor genes, then this fine balance is lost, and that's when the cells can go on to divide in an unregulated fashion, and that leads to cancers. And I should say that this is a very simplistic way of describing cell cycle regulation. In reality, it's a very complex process involving lots of genes. Now, we know that cancer is not a one-step process that happens all of a sudden. Cancer occurs in various stages over time, and this occurs due to accumulation of gene mutations over time. So if you have a normal cell that has its first mutation, and it might go on to becoming hyperplastic. What I mean by hyperplastic is the cells are dividing rapidly, but they're still maintaining their typical features that helps us to distinguish from which tissue they come from. Further mutations then can lead to dysplasia, wherein the cells are dividing rapidly, but they've also lost the typical features that help us to distinguish from which tissue they come from. Then they can then go on to develop into carcinoma in situ, where there are these cancer cells, but they're contained within the tissue barrier. And further mutations then lead on to full-blown malignancy, where these cells have divided to such an extent that they've crossed the tissue barrier and spread to other organs as well. So cancer doesn't develop in one stage all of a sudden, but it develops because of this accumulation of mutations over time. And this is where screening becomes relevant. And the aim of any screening method is to pick up these cancers quite early on, perhaps in the hyperplastic stage or dysplastic stage, rather than when it's a full-blown malignancy. Right. So this slide is just an overview of carcinogenesis. So any normal cell is undergoing DNA damage constantly because of various factors, including environmental factors. Say, for example, smoking. So smoking produces these hydrocarbons which could damage the DNA. So when there's DNA damage within the cell has to either repair the DNA by means of various DNA repair genes, and BRCA genes are one of these DNA repair genes. Or if it's unable to repair the DNA, it's supposed to go down the route of cell death or apoptosis, and that's where tumor suppressor cells such as p53 come into action. But say, for example, there are mutations in these genes, then the cell escapes both these routes. It doesn't repair itself, neither does it go down the route of cell death. It escapes both these routes and goes on dividing, and that's what leads to cancers. Now, this is just to highlight the various cancer susceptibility syndromes that we as geneticists see in our clinics. I think we are more familiar with BRCA mutations, which are inherited in an autosomal dominant. All these genes are inherited in an autosomal dominant fashion. And as Dr. Bowell mentioned, it can be inherited both from the maternal side and paternal side. So it doesn't matter if it's from the mother's side or the father's side, but it would have a 50% chance of being passed on to the next generation. So we know that BRCA gene mutations increase risk of breast cancer, ovarian cancers, and with BRCA2 mutation, it also increases the risk of male breast cancers and these other cancers, pancreatic, melanoma, and stomach cancers to some extent. We also see families with Lee-Fromini syndrome. This is a very rare syndrome, but we do see families with this syndrome. This is caused due to mutation in p53 gene, and this predisposes individuals to developing breast cancer. Women with Lee-Fromini syndrome can have breast cancers very early on in their life, even before the age of 30 years. And there's also increased risk of developing sarcomas and brain cancers. Now, one other syndrome that we see is Cowden syndrome. Again, this is caused due to mutation in a gene called P10 gene. Now, individuals with Cowden syndrome have an increased risk of developing breast cancer, thyroid cancer, endometrial cancers. But they also have increased risk of developing benign tumors such as lipomas and fibromas. So it's important to take a history about these benign tumors as well while considering a diagnosis of Cowden syndrome. And one of the distinguishing features of Cowden syndrome is individuals tend to have a slightly bigger size, head size, compared to their height. And this is one of the, it's a good marker for picking up people with Cowden syndrome during the clinics. We also see patients with Pearce-Jaeger syndrome, wherein patients have increased risk of developing bowel polyps, which can turn into bowel cancers. They have increased risk of developing breast cancers and various gonadal cancers as well. And more recently, we know that patients with a syndrome called neurofibromatosis type 1, which is mainly a syndrome that has various signs on the skin. Individuals can have cafe au lait spots, which are just coffee brown spots on the skin, and they can have these benign tumors on the skin called neurofibromas. The women with NF1 have moderately increased risk of developing breast cancers as well. Now, this is just a slide summarizing our care pathway for our patients. So we get referrals from our colleagues from primary care, GPs, and also from secondary care, and also other specialists like gynecology colleagues, breast surgeons, and oncologists. And we work very closely with all these specialties to provide appropriate care for our patients who are at risk of breast cancer and ovarian cancer and other related cancers. Now, I would like to finish my talk just by highlighting some of the news that have been in the media recently that might change the way we manage our patients with breast cancer in the future. So the first piece of news was published in April last year, wherein these researchers from Cambridge classified breast cancer based on the DNA fingerprint of the tumor itself. The conventional way of classifying breast cancer is by the histopathology of the breast cancer, but these researchers actually classified it based on the DNA fingerprint. This would change the way we look at tumors in future, and also it paves a path for developing personalized medicine in future. So in future we wouldn't be offering the same treatment for all patients with breast cancer, but we'll be offering tailor-made treatment for individuals based on the tumor markers and the DNA fingerprint in each of those tumors. So on same lines, David Cameron made this announcement I think in December last year around this 100,000 genome project, where I believe they've ring-fenced £1 billion for this project. And the aim of this project, from what I understand, is to do genome-wide sequencing of 100,000 patients with cancer, and in time to come develop a database based on the information that we gather from this 100,000 genome-wide sequencing. So again, the aim would be in time to come to develop personalized medicine based on the fingerprint, DNA fingerprint of these tumors. Last but not the least is the tamoxifen story, which is more recent, just a couple of weeks ago, from the latest NICE guideline, which is still in consultation at the moment. They're recommending tamoxifen for women who are at high risk and moderately increased risk of breast cancer. And I think Dr. Bowell is going to be talking about this in more detail in a few minutes' time. I'm just going to leave you with referral guidelines for cancer genetics. Thank you. I'm happy to answer any questions if you have any.
Excuse me, could I ask a question? Go on. Could you say anything about the link between estrogen-dependent cancers and the BRCA1, BRCA2?
So that's what we know is with BRCA1 mutations, women were diagnosed with triple negative breast cancer, that's they're estrogen negative, but also progesterone negative and HER2 negative breast cancers before the age of 40 years. There's a 10% risk of them being linked to BRCA1 mutation. So BRCA1 is more related to triple negative rather than estrogen positive. And that's where I think tamoxifen, treatment with tamoxifen, we need to link that in choosing the right kind of patients for tamoxifen. Thank you.
Thank you very much, Joyce.